Dr Robert Marchl. I'm a consultant psychiatrist. I work as a clinical leader integration for Counties Manukau, and I've been here for 11 years. So my understanding is that I sort of tell you about how our systems are generally set up. We've got 2 home-based treatment teams that can function as a step down or step up. So if somebody is having early warning signs, we can ask the home-based treatment team to support them at home, support with medication, more intense sort of daily supervision, contacts, sort of saying, okay, well, if you have daily contacts, then you can be sort of more proactive in terms of medication, because you can follow up and say, well, has that helped? Yeah? And essentially try and continue treatment at home in their environment that sort of suits them well. And obviously they have to be safe, and the family has to be safe and willing. So that's home-based treatment teams. We also have a number of subspecialty teams. So we have an early psychosis intervention team that does exactly what the name says. We have an infant team that looks at, usually that works together with the maternal mental health team, that sort of looks at mother-infant bonding, especially if there are mental health concerns. Then we have an intensive community team that sort of deals with, as the name says, deals with people who've got very, very complex, usually psychosis. So my particular work, so I'm, as I said, the clinical lead integration. So ever since I started as a consultant, I've been running like a peer review group for GPs. Well, the project has been going on. We've kicked off that we now actually have a set of entry criteria and then a prioritization tool. So for patients that we do think need to go to a community team for a one-off med review, or might be more, we have clear entry criteria that we are currently sort of in the second test phase to sort of get an idea, well, are they fit for purpose? Yeah. Are the sort of our risk complexity criteria, do they actually sort of meet what the patient needs? And we also still have the ability to override. So what I say, gut feeling or individual clinical impression. If I think, well, I want him to go into a community team, it doesn't meet the criteria, well, I can still. Yeah, so it's not a hard decision. Yeah, and because we have been testing it over the sort of last half year, it does work. We've also got a psychiatrist advice line for GPs. We've got currently, including myself, I think we've got 5 psychiatrists manning. That's Monday to Fridays, business hours, so 8:30 till 5. Whatever. I've had people call me 5:15, I still answer. So that's for GPs to be able to call and talk to psychiatrists and say, hey, I've got this patient with me. I've tried this, I've tried that, what do I do now? And then you have a phone conversation. The onus is on the GP to actually document that. Because also, like I said, counties, so we were far ahead of the curve in terms of actually employing peer support specialists. There are other services in New Zealand that don't have them. Yeah? There are some that have, they've got access to peer support specialists, but the peer support specialists are not employed by them, so they work more on sort of voluntary basis. Then there's some that are employed by NGOs and then help out as community support workers. And we're actually, our general manager actually just spent half a year secondment to try and roll out a unified and centralized system of peer support specialist support for all mental health teams in New Zealand. And that work is still going on.